I'm David Entebbe. On behalf of the board and members of Hazak, I want to welcome everyone to our discussion this evening on the pandemic. Doctors Jeffrey Kahn and Mark Meiches are once again going to share their insights with us and provide the latest and most relevant information about how COVID-19 is changing, yet still affecting our lives. I've lost count, so I'm not sure if this is the fourth or fifth iteration of the program, but at any rate, it's been too many, and we all wish that we wouldn't have had to gone through it to this extent. I want to say thank you to Mark and Jeff for being so generous with their time and for being willing to share their expertise on the pandemic with us. We are indeed fortunate to have members like them part of the Anshai family. I'm going to turn the program over to Mark, who will serve as moderator. Jeff will then provide his insights, followed by a question and answer period. I would like to thank Phil Bayless for coordinating the program this evening and for compiling all of your questions. We'll be recording the program as some people are unable to attend. Mark, I turn it over to you.
Thank you very much, David, and thank you very much, Phil, for giving us both the opportunity to address you. And as you all know, Jeff's the one with the insight. I'm just here to moderate and pass on questions. We're going to do this as we have in the past. To make it simple, I'm going to ask everyone to send the questions to me, and then I will call them and try to summarize them and feed them to Jeff as we go or toward the end. Phil has already sent me a large number of questions that you all have asked. I suspect a lot of these will be answered by the time Jeff's done talking, and I'll go through those, but whatever he didn't cover, we'll certainly try to bring up in the time we have. As David mentioned, this is we've been here too many times. This is actually our fifth time, so we're in good company. There was a Rocky 5, a Police Academy 5, a Nightmare on Elm Street 5, American Ninja 5. So just in good, if dubious company. One standard disclaimer, as we always give, the information Jeff's going to give is a general, and while it applies to seniors in general, every one of you has different specific medical conditions and issues, and anything that you have any concerns or specific questions about, you should address with your doctor specifically. So on that note, I'm going to turn it over to Dr. Jeff Kahn, the Chief of Pediatric Infectious Disease at UT Southwestern. Jeff, thank you for being back with us.
Oh, thank you, Mark. And hello, everybody. Wow, I can't believe this is the fifth time we've been doing this. Do have a short presentation. I think that will be a good runway to get to the questions. So I'm going to share my screen here. Let's see. Share. And can you folks see my screen?
Yes.
All right, let me just do this and go to slideshow. And whoops. All right, I think we're good to go here. So the first topic I'm going to talk about here is epidemiology. And I'm sure many of you saw this at the front page of the New York Times back on May 15th, or just 16 days ago or so. 1 million. We've surpassed this very grim, almost unimaginable milestone of 1 million people in this country have died of COVID-19, and it's really a moving article here if you get a chance to read it. But you can see there are dots here, and each dot represents a person who has passed away because of COVID. Again, it's unimaginable, the grief that has come with this pandemic. And again, if you do the math, 1 in 331 individuals in the United States have died of COVID. Really, just extraordinary numbers. Brown University did a very interesting study, and they actually published this on their website under the heading of Global Epidemics. And they actually asked a very interesting question, and that was, how many deaths could have been prevented with vaccine? And they looked at the data from January 1st, 2021 to April 30th, 2022. And the reason they picked January 1, of course, as many of you remember, that the 2 mRNA vaccines, Moderna and Pfizer, were approved in December of 2020. So January 1, 2021 was when vaccines became available for the most part, although I would certainly say for January, February, and probably March and into April of that year, there was limited supplies. But nonetheless, they took a look at this and they did some calculations, not to get into the weeds, but you can imagine what they did was they looked at people who died, how old they were, and whether they've been vaccinated or not. And here, the numbers are really just staggering here. So they calculated that the vaccine preventable deaths in the United States, 318,000, actually almost 319,000 deaths could have been prevented by vaccines. And again, it's a data-rich website, and if you go to the website, and it's down here, you can see they break it down by state, and there's a lot of rich data in here. But I just pulled up the data for Texas. So 59,795 people as of April 30th have died in Texas due to COVID. 29,773 could have been prevented with the vaccine. So it's really, it's just, it speaks to a lot of issues, of course, vaccine denial and a lot of the rhetoric we're hearing about vaccines. And there's a real cost to this. There's a real cost to people propagating these lies about vaccines. But anyway, and here, this is the miracle that fell short. This is what they talk about. Every second COVID death in 2021 could have been prevented by vaccines. And here's one chart. Again, there's a lot of charts here that look at the percent of people in different countries who've completed their initial COVID vaccination protocol. And you can see that the United States, among the countries listed here, is last. Okay, let's talk a little bit more about epidemiology. And this is COVID-19 in the United States as of this morning. And this is all from the Johns Hopkins website. And if you look on the left-hand side here, you see this is going from March of 2020 all the way to today. And on the left is cases, deaths, and hospitalizations. And what's so striking about this is that here are the separate ways, but when Omicron hit, there was a huge increase in cases, as you can see here, and not necessarily a proportional increase in the number of deaths or hospitalizations. And this speaks to a lot of the factors, and we can perhaps touch on that later. But what's been going on in the last 90 days? And you can see it's been relatively flat across the United States. In cases, deaths are going down, hospitalization may be going up a little bit. So there's still sort of low level activity, and it depends on where you are in the United States. It differs. So if you look at Texas, you could see that, again, this was the Omicron peak here. And you can see that the cases have remained pretty low. Deaths have been very, very low compared to earlier in the pandemic. Hospitalizations also very low. And one of the other metrics they look at is hospitalizations, beds, ICU beds, non-ICU beds. And you can see that the percentage of beds occupied by COVID patients is very, very small right now. That's would be the light brown. The teal color here are non-COVID patients. So, you know, we're certainly at a much better place now than we were several months ago or even a year ago. Now, one thing I should mention is that when you look at cases, this is reported cases. And I will tell you that over the last month or so, I've gotten a number of calls from family members, friends, associates, colleagues, and so on and so forth, who have COVID. And without exception, all of these have been diagnosed using a home test. So it really calls into question, well, how many real cases are there? So it's really becoming quite difficult to count cases. I'm not suggesting that home testing is bad. I'm just suggesting that it's tough to count cases now because of home testing. However, relatively speaking, it's much easier to count hospitalizations and deaths. And you can see, so I think, you know, this data certainly reflects what we're seeing up here. So it looks like the trends are at least moving in the right direction. Now, I often look at New York because the trend has been throughout the pandemic that what's happening in New York usually precedes what's happening in Texas by 3 or 4 weeks or maybe a bit more. And you can see there was an uptick in the number of cases, again, taken with a grain of salt because we don't know the true number of cases. Deaths have remained really low, and there is a slight increase in hospitalizations. So maybe that's what's to come. You can see that they seem, again, the brown color is the percentage of beds that are occupied by COVID patients. It's very small numbers, and I think during one of the previous iterations of this update, there was a lot of brown or tan color in this bottom graph. So we're really at a much better place, and certainly for New York, early in the pandemic, they were full, and we all remember the stories there. So again, looking at Dallas County, the numbers are very low. This is from the Dallas County website. This is their weekly publication. They haven't updated this since April 29th, but be that as it may, very large Omicron peak, very narrow, intense. Things have quieted down rather significantly. And again, this is the positive test reported to Dallas County Health and Human Services by the hospital laboratories. The red line is what I really think you should focus on. The red line is the percent positives. And you could see during Omicron, 50% of the tests obtained were positive for COVID. Things have gotten really low. In fact, we reached a low point here just last month, and it's increasing a little bit. And clearly, this is consistent with sort of national trends, but it's a very slow incremental incline of the number of cases. So I want to talk a little bit about what's going on in Dallas County. I think this is really quite informative. Again, the Dallas County website is listed up below. And Dallas County has been keeping track of vaccine breakthrough cases. So these are people they're looking at people who have gotten the primary vaccine series. And that would be 2 doses of Moderna or Pfizer or just the J&J vaccine. And they've identified 74,000 people who have met the metrics. In other words, 74,000 breakthrough cases. Now, if you think about that, that's a very big number. Mind you, the total number of cases is 590,000. But let's dig a little bit deeper into these numbers. So here's the cumulative whoops. So again, that's what I just pointed out to you here. Look at ever hospitalized. So of these 74,000 individuals who have had vaccine breakthroughs, how many of them been hospitalized related to COVID? And the number is actually quite small. It's about 1,300. Now, there's still another 2,000 or so that are pending investigation. So let's just argue that all of these are due to COVID. So this would be about 3,300 vaccinated individuals who are hospitalized with COVID. But look at this. The total hospitalizations is 36,000. So of the total hospitalizations in Dallas County, less than 10% are in vaccine people who've been fully vaccinated. And you can take this one step further, looking at the number of total deaths, 6,400 in Dallas County. And again, looking at deaths caused by COVID, 509 pending investigation. So this is about a little over 600, again, about 10%. So, in the initial vaccine trials, it showed that these vaccines were 93, 94, 95% effective. And here in real world numbers here in Dallas County, it looks like, as far as hospitalizations and deaths, these vaccines are about 90% effective. So that's very, very good news. And again, this is cumulative data as of May 20th, 2022. So this includes the Omicron peak as well. Okay, so my colleagues at UT Southwestern have this very robust modeling system, and I'll show you a graph in a moment. But this is the commentary. I've highlighted some here. So while the number of people hospitalized in the region remains low, hospitalizations are expected to slowly increase over the next several weeks. Test positivity rates are increasing. Again, total testing volumes remain near all-time lows because of home testing. I think that's one of the major factors. Based on these trends, our medium-term forecast predicts that hospitalizations should remain at low levels throughout the spring, but rise again in the summer. They talk about the variants. I'll talk about that in a moment as well. But again, the breakthrough infections are occurring in individuals who have been vaccinated. But if you're not vaccinated, you're at much higher risk. And I showed you the data a moment ago. So this is their trajectory for Dallas County. And just to orient you to this graph, this is occupied beds. Each one of these black squares is real data going from July of 2021, July of 2020 to where we are right now. And so you can see these are the different waves of the virus. This is the wave in 2021. This is the Delta. This is the Omicron wave. And these two lines here, the blue and the red, are projections based on their modeling system. And you can see it, they're projecting that maybe in August or September, we may be at a point now where we're going to start seeing an increase in hospitalizations. Now, this is, of course, a long-term projection. We'll see what happens as time goes on. I think in the list of questions that was submitted, There was a question about children, children or grandchildren. What do we do about children? And here's the data of the American Academy of Pediatrics and the Children's Hospital Association actually puts out data about COVID. And this was published on May 19th. The latest report was supposed to be published yesterday, but it was Memorial Day, so they published it today. It wasn't online when I made up the slide deck. Needless to say, this is a summary of publicly reported data from 49 states: New York City, District of Columbia, Puerto Rico, and Guam. So there's one state missing. Just take a guess at what that state is. Yes, it is Texas. So they don't have any data. The problem with Texas is that they don't give an age distribution for their COVID data in children. Needless to say, 13 million total COVID cases reported. Children represent 19% of all cases. And again, some of the data here, the cumulative hospitalizations from some states, as you can see here, about 1% or so. And again, fortunately, children tend to get less severe disease, but there are serious infections with COVID. I've seen them here, and children have died of COVID. And in fact, here's the data right here. Over 1,000 children in the United States have died of COVID. Again, this data is a little bit, it's a couple of weeks old, I believe, but you can see the breakdown right here. All right, so let's move on to the variants. There's been a lot of questions about the Omicron variant and the BA2 and 3 and 4 and 5. And here's the latest data from CDC as of May 28th. It's a bar graph over here. And so this is the week ending February 26th, and each bar represents another week. And each color represents a different variant. So this very dark purple here is sort of the initial Omicron variant. I'm sorry, this one here, this light purple. And then BA1 was the sort of derivative of that. And then this BA2 variant sort of took over and became the major variant. Now there's this BA2.12.1. And there's been a lot of noise about this. And certainly there are subvariants that are popping up and circulating. Most of them seem to have the same characteristics, at least clinically and epidemiologically, as the previous BA2 Omicron variants. But this is somewhat predictable that the virus is going to continue to evolve as it moves its way through the population. The big issue is going to be, or the big fear is, that there's going to be a new lineage, a completely new variant that comes through. And that we learned that lesson with Delta, and we certainly learned that lesson with Omicron. And there are 8 letters left in the Greek alphabet. Hopefully we won't go through all of them, but the next letter up will be pi. But that's going to be the big issue if a new variant emerges, because then we may see what we saw in the past with the variants. Okay, so a number of questions about vaccines and boosters, and I'll go through this very quickly. You go to the CDC website, COVID-19 vaccine, quick reference guide for healthcare professionals. It's great information here. I'm going to show it with you. Here's the website. It's easy, just Google it. So this is the vaccine administration. I put this up here for a couple of reasons. First of all, it's a nice summary. The CDC already did this, so I don't have to reinvent the wheel here. And the thing to note here is, and this is where it gets a little bit confusing, and nomenclature gets a little confusing. The 2 doses of either Pfizer or Moderna, that's the immunization schedule. And if you've gotten 2 doses, then you're considered immunized. And we'll talk about booster doses in the next slide. And here are the recommendations. You can see that right now, Moderna only approved for ages 18 years and older, where Pfizer is 5 through 11, 12 and 12 and up. And don't worry about the orange cap, there's a purple cap, gray cap. That just has to do with how the vaccines are distributed and the vials and so on and so forth. That's not quite relevant here. And I'll talk a little bit about what's coming up in June, about perhaps expanding the eligibility for a vaccine. So here's the booster schedule. And again, not to go too far into the weeds. If you're relatively healthy and you're not immunocompromised, and you've gotten a 2-dose mRNA vaccine, you can get your booster dose, and it's listed here. If you are immunocompromised, I should mention one thing that was on the previous slide. If you are moderately to severely immunocompromised, your primary vaccine series is actually 3 doses, not 2 doses. And you can get a booster dose after that. So again, some people talk about their 4th booster dose. Well, it's really the 2-dose primary series and then 2 booster doses. And perhaps we can go a little bit more into that during the question period. So just to sort of wrap things up a little bit, there have been some questions about, hey, what's going on? What about more booster doses? What about children, particularly for the Moderna vaccine? What about kids who are less than 5 for the Pfizer vaccine? And in fact, the FDA is having an advisory committee meeting on June 14th and 15th, just 2 weeks from today, 2 weeks from tomorrow, or today actually, to discuss this. And this is an open meeting. It's open to the public. You can join. You can submit questions. You can submit data. If you go to the website, they'll tell you how to do all that. And here's the agenda for the first day. The committee will meet in open session to discuss amending the emergency use authorization of the Moderna vaccine to include administration of the primary series to children and adolescents 6 years through 17 years of age. So this is, mind you, right now Moderna is only 18 and above. So this is going to be their topic for topic 1. And on the next day, and again, I'm highlighting some of this. The next day, under topic 2, the committee will meet in open session to discuss the emergency use authorization of Moderna to include administration of primary use to infants and children 6 months of age to 5 years of age, and also discussing amending the emergency use authorization of the Pfizer vaccine to include administration of the primary series to infants and children 6 months of age to 4 months of age. So perhaps by the end of this month, we may have 2 vaccines that are going to be available for children who are 6 months of age or older. So I suspect that this is going to get a lot of press in a couple of weeks, and we'll see what the FDA says. And of course, once the FDA makes their recommendations to CDC, the Advisory Committee on Innovational Practices will make their decisions, and then the official recommendations will come out. And then I think there's going to be more and more discussion about booster doses as we move along here. So in summary, there's low levels of SARS-CoV-2, which is the virus that causes COVID, nationally, regionally, and locally, though there are increasing cases in some areas. Hospitalizations remain low. The latest models project increase in number of cases and hospitalizations. Vaccine effectiveness remains high despite the emergence of new variants, and the vaccine recommendations are likely to include young children. So that's what I have here. I'm going to stop sharing, and I'll turn it over to Mark.
Thanks, Jeff. I've got some questions in the subjects you've covered, and then we have a couple other subjects people have asked a bunch of questions about. I think I'm going to ask you to address after we answer some of those. So let's start with the children. Pending any changes in June, several people have asked, what do we do with our kids who are under 5? And some of the data you showed is that there are very, very few deaths there. Is that because these young children are not getting the disease, or are they getting it, but they're simply handling it okay?
I think it's more of the latter. I will tell you that during the Omicron wave, which was really January, February of this year, at Children's Medical Center Dallas, we saw more COVID cases during the Omicron peak than we saw throughout the entire pandemic. It was rather extraordinary. We saw a lot of young children, a lot of infants come in with COVID, and older kids too, kids with no underlying risk factors. So we were seeing that. So it could be that the virus is, perhaps the Omicron, we know the Omicron is more transmissible, kids were getting it. And the more kids who got it, the chances are that we're gonna find those few kids who got really sick. So that's the data here. I should also mention that the CDC published a report back in April that showed 80% of children have evidence of infection in this country. So that's quite extraordinary. So yeah, so the kids certainly are prone to severe disease. Thankfully, a lot less prone than other age cohorts.
So I know you can't make an absolute call, but pending some government intervention where they, again, mandate masks for little kids, when school starts again, if nothing significantly changed, how do you feel about masks for the 5-year-olds, for the less, kindergarten and nursery school and that sort?
Yeah, so this has really been a hot topic in the third rail for a lot of people, and people have gone to their corners and argued about this. I think we have to be very nimble about this, and that is that the virus is here to stay, and they're going to be consistent. They're going to continue to be outbreaks, hopefully small outbreaks, and increased number of cases, and we're really going to have to roll with the punches here. I think if we see a big increase in number of cases, then we should start wearing masks again. If not, then you have to sort of think about the utility of wearing masks now. So it really depends on where we are at the end of August.
Well, specifically the little kids too.
Right, the little kids, right? So that brings up an interesting and very challenging question. And there's so many levels to this, right? We know the virus is very transmissible. Little kids tend not to wear the mask very well, although there's plenty of data to suggest that the mask worked really well. And by the way, if you're really interested in this, the last time I checked, the CDC has actually a web page talking about the effectiveness of masks. And the last time I looked, there were 65 studies that were actually referenced in that on that page, maybe more now. So masks really work, but I think we really have to see the ebbs and flow of the pandemic. I think if we start seeing numbers increase like we did at the beginning of the Omicron wave, by all means, yes, we gotta put an end to this. And certainly if a new variant shows up, then we may be back to square one. So it's a difficult call. It could be that in certain areas they should be wearing masks, in certain areas they shouldn't be wearing masks, they don't have to wear masks. But this is a very, very difficult situation.
Let's go into the variants. You talked about, and people asked about the different strains, BA 1, 2, 3, 4, 5. Isn't it true that there's really usually, however many are out there, there's usually one that dominates and takes over? Is that correct? So people don't need to worry about their three at the same time, particularly. Is that fair?
Yeah, right. So this is sort of the natural evolution of these viruses. Some of the, as a variant, they all mutate, and as they pick up a mutation that may be more favorable for their contagiousness, then they'll take over. And in fact, we knew that. A perfect example of that was back in November. Essentially, every strain that was looked at was Delta. And the Omicron virus was first identified in the United States December 4th. And by January 1st, it was all Omicron. It completely took over. So it's sort of survival of the fittest. And if you have a virus that is very good at transmissibility, it's going to overtake everything. Now, transmissibility and virulence are two different things. And so I think it's important to note that even if a virus is more transmissible, doesn't mean it's more dangerous. Obviously, it's going to be more dangerous on a population level because more people will get infected. But for an individual, it may not be.
And so if there are 5 variants, 4 of those may never come to our consciousness because they've never taken hold. Is that right? So people read about a lot of them, but don't assume there's going to be necessarily 4 more coming or 4 at once.
Right. And again, if you look back at the graphs I showed, the Omicron peak, very intense, very narrow, died down in February, and things have been sort of slow. But for example, in the beginning of March, it was the BA1. And then now it's BA2, but then the shape of the curves, number of cases, they really haven't changed all that much. So we have another name for this, a new variant. And again, we can get into the weeds about that. A new subvariant, I should say. But it doesn't seem to be acting all that different from the parent variant.
In our first talk and our second talk, you told us about how the surface proteins are really things that were getting mutations. And you talked a little bit about, if that changes to some other part of the molecule or the virus, that's an issue. Where are we going? Is it still a surface protein, or are we finding some changes?
Yeah, well, there's changes throughout the chromosome, if you will, of the virus. But the most important ones at this point are the ones in the surface proteins, the spike protein that people talk about, because all of our vaccines are based on the spike protein. So if the virus spike protein changes, that means that the vaccines are going to become less effective, potentially less effective.
But none of the ones we've seen so far has that not been a factor now. We're still responding to spike protein drugs, if you will.
Right. If you look at the immunity induced by the vaccines and look at them across the board of all the different variants, certainly the vaccines was most effective against the initial strain, because that's what the vaccines were based on, that initial strain. efficacy or the immunity that's induced by the vaccine against Delta was a little bit lower, and against Omicron a little bit lower. But this is just looking at antibody levels in blood. It doesn't necessarily translate to clinical efficacy. And again, at the beginning, I showed you the data that shows that these vaccines are still very, very effective.
So this is a question I don't know if I want the answer for, but in the history of viruses like this, with the flu virus, we all get vaccines, but in a given year, the flu may be mild, and the next year it may be really bad. Even with people getting vaccinated and the benefit you're showing that, is it possible that the second or third or fourth next one may just be extraordinarily devastating in some other way? Or is the history of these viruses as they evolve typically like this, not ever having a horrible type change?
I think the history is that these viruses tend to become less virulent, or the impact, I should say, that the impact of the virus becomes less over time. And that has to do with a lot of things. One, of course, is that people are getting infected, they're developing natural immunity. Of course, now we have vaccines, they're getting vaccine-induced immunity. So the virus is going to start, the spread of the virus is going to decrease dramatically. Yes, there is a chance that it may mutate to a more virulent strain. That's always a possibility. As I said before, if another variant emerges, then we may be in a lot of trouble. But things tend to even out over time. And I should mention that there are 4 common human coronaviruses, and they've been circulating in the human population for a very long time. And for all we know, they each started like COVID, with a lot of spread, and then it died down, and then there are little episodes, outbreaks, epidemics here and there. And of course, perhaps when these viruses first emerged, it was 200, 300 years ago, and there wasn't the kind of global travel there is now. But we know a lot about the 4 common human coronaviruses, and they cause sporadic outbreaks, and they're really not a problem. And that they cause the common cold. Yes, they can cause severe disease in certain populations, but for the most part, they're pretty innocuous.
So someone just asked a relevant question: how do epidemics like this ultimately end, if they do? Is it a matter of, as you're saying, they just wean down until we're pretty much just a rare sporadic thing?
Yeah, and that's basically it. What's going to be very interesting here is how durable immunity is, not just by the vaccine, but by natural infection. I think that's a very interesting question. And now there's some data to suggest that even natural immunity induced by natural infection wanes over time, which is a little bit different from some of the other viruses that we've encountered. Measles, for example, once you get infected with measles, you're eventually, and you survive that, most people do, you're immune for life, and the virus disappears. And now we have a very effective vaccine against measles, but I suspect that over the next couple of years, it's just going to be one of the viruses that's circulating, and it's going to cause local outbreaks and maybe small epidemics here and there, and it's not going away.
So what you just said a minute ago sort of segues into the next category, which is the boosters and the timing of these. There are 4 available now, or the 4th shots. So can you tell us, who should be getting those, what to expect from, when should the next one be coming? Do people need the 4th, or only certain people, and what the circumstance? And also sort of tying into that, I think everybody's pretty familiar now that boosters start losing their effectively 4 to 6 months. So how should people maybe time that 4th booster, depending on a surge or vacation, that sort of thing? Give us some guidance on when you should be getting it and what the strategy is going forward.
Right. And what you just said, I think, is the most important thing, in that we know that the effectiveness, the booster's effectiveness is within a week after you get the booster dose. That's when your maximum benefit, and that will last for several months, and then the immunity starts to decline. Now, and although the immunity is declining, you still have protection even after that. So if you're thinking about traveling in August, then maybe not be an idea to get a booster shot sometime in mid-July. Now, the rest of it is like reading tea leaves, right? Like, all right, I'm going to be going somewhere. I want to go up to New York on Thanksgiving. Well, should I not get my booster dose now and get it, at the end of October? But we don't know what the virus is going to be the circulation of the virus is going to look like And so what should I do? And then the counter argument is, well, if I get it now and there's a new variant that emerges in September, what does that do with my vaccine? And so there's a lot of unknowns here. But what is known, again, is that vaccines are very effective. Get your booster dose. And again, if you want to delay it a month or two, I'm really no objections to that. But after that, it's a lot of, as I said, reading tea leaves. We don't know. We have no idea where we're going to be.
So go ahead. When we say a vaccine loses its effectiveness after 4 to 6 months, people are asking, what does that exactly mean? How does that happen? Is that the mutations?
No, so what basically happens is that the immunity in your body starts to wane over time. Now, our immune systems are very sophisticated, and even though we can measure antibody and see antibody going down, that doesn't mean that the effectiveness is different. But again, our data suggests clinical effectiveness also may wane over time. So that's the big issue. And getting back to the timing of boosters, think about this. Before November 26th of 2021, nobody heard of the Omicron variant. It was the first isolate of the Omicron variant was in South Africa, November 9th. So on November 8th of last year, nobody had heard of that. It was unknown. And you can see how dramatically over 2 months, how things have changed. So that's why I'm saying that sometimes it's a little hard to predict more than just a few months down the road.
Well, this relates to another question someone just wrote in. And what is it that takes whoever they are, so long to get a new booster? I mean, they're not, I assume they're not just reacting to what's out there currently, but they're trying to project things, but that may not be right. So why does it take so long to get a new booster? Why aren't there new boosters every 6 months or whatever, hopefully keeping us safer?
So I'm sorry, so is the question, why aren't they scheduling?
Why does it take so long for the next level booster to be developed?
Well,
what prevents them from?
Right, so the booster doses are the same as the original vaccine. Sometimes at a lower dose, but they haven't reformulated the vaccine to address the new variants. I don't know if I'm answering your question or
No. That I think that clarifies the person's question, is why they don't do it more often. And they're continually studying to see if doing more frequent boosters would be beneficial. Right.
I mean, ideally, we should have the booster dose should contain the Omicron spike protein, because now instead of this misalignment between the vaccine and the virus that is circulating, well, let's reprogram the vaccine so it matches Omicron or BA2 Omicron. That unfortunately that has to go through a lot of testing, and then there are some studies that are out there looking at this, but it may be a while before we retool the vaccines.
Okay, because as you remember, when this all started, we had all sorts of different questions, but right now we're sticking with what we have, and even though there's research going on, we're not changing the strategy.
That's correct.
We've read about nasal ones and other ones, and right now we're going the same.
Right.
Okay, thank you. We've got some more questions about boosters and the timing thereof. Let me take a peek at these. Okay, so can you give us an update on Pfizer versus Moderna versus anybody else in terms of, not specifically for children it was asked, but certainly I'd like you to broaden that for everybody. Have you found any trends, one or the other, or is it sticking to doesn't really matter?
I think that it's splitting hairs. These are both highly effective vaccines. I've been asked the question about, well, I got my initial series from Moderna. Should I get the Pfizer booster, or should I stick with Moderna? Do whatever you want. If you feel more comfortable switching over, then switch over. If you want to stay with what you had, stay with what you had. The differences are really minimal.
As you've noted, and I think our audience has learned from our last sessions, most of the people, even with the vaccines, who do get ill or more significantly ill are in the older contingent, either immunosuppressed or the seniors. And that's who a lot of our audience tonight is. So is there anything else that they should do other than getting their boosters that they can do to protect themselves above and beyond? They're the ones at risk, the greatest risk.
So, it goes back to, if you're going out in public, wear a mask. If you can avoid large crowds, indoors, then do that. And
even though the numbers right now you're showing are low.
Oh, low, right. And if you want to be ultra cautious, there's still virus circulating here in Dallas County. But if you want to be ultra cautious, then stay away from large crowds and indoors. And then be mindful of the people who are coming to visit you. or you're interacting with. Again, even though the virus is very low right now, there's virus circulating. So if you're going to be, if you may come in contact with young people or people who have not been immunized, then be mindful of that. And so it's, sort of a throwback to the beginning of the pandemic. Do the things that will keep you safe. Wearing a mask, washing your hands, and just being COVID alert, I guess, is a term we could use. Yeah.
Two more quick questions on this sort of broad subject. In the past, you've shown us some really nice graphs. I believe they were from UT Southwestern about what's coming in the next few months. You didn't show us any. Do we have those graphs yet? I know it's harder and harder the more people are getting boosted, but do you have any idea when the next surge is expected, or do we not really have that figured out yet?
Well, the long-term projections
just for vacation planning and all, people are trying to know when it's hitting.
Right. Now, of course, that depends on where you're going.
Right. Of course.
So I would say that probably August, September is maybe where we'll start seeing some more increase in the number of cases. But we'll see. That's pretty long. That's a long ways away. But that's the latest projections. I mean, obviously we feel more comfortable and more confident with the short-term projections, which from UT Southwestern have been remarkably accurate. But once you get past a couple of weeks, all bets are off.
One last question in this area. Update us or remind us, it may still be the same. If someone does become ill with COVID and they do a home test that's positive, and then they recover, how long are they protected from getting it again? And if they get it again, will it be the same variant, or we're not so sure if it's really another incidence, but are you protected in the short term if you got it last week and you had a mild COVID?
Right. So in the short term, particularly now, because there's only Omicron, the subvariants of Omicron are circulating, but particularly now, if you've gotten COVID in, I would say, the last 6 months, so anytime from December on, it was most likely Omicron, and you're probably pretty much protected. I've gotten a number of calls from people who've had mild illness, and I asked them, well, are you been immunized? And they say, yeah, I've been immunized, and I've been boosted, and I got a cold due to Omicron. I say to them, well, you are the ideal person for protection because you've been immunized, you've had a natural infection, your immunity is going to be as good as it's going to get right now. So your likelihood of getting reinfected is very low. The reinfections that we tend to be seeing now are people who had infection before Omicron or even before Delta, and now they're getting reinfected. But for the most part, reinfections tend to be a lot less severe than the primary infection.
And in that light, if someone does have a mild illness, they test at home and it shows it's positive, you get your little bar. Is that good enough? Should people call their doctor, or should they say, I've got it, it's a true test and I'm fine? What do you recommend if someone does get a positive finding?
Call your doctor. Yeah, call your doctor for a couple of reasons. One, it's good to have it documented. That's very important because you may not remember when you tested positive or whatever. Two is that there are medications now, oral medications that are available, that if you happen to fall into a risk group and you have mild illness, well, you may want to think about taking that medicine because it may progress into a severe infection. So there are oral medications. Of course, there are intravenous medications as well. It depends on your history, but for all, yeah, by all means, if you test positive, let your doctor know and discuss it with your doctor, with him or her, and ask about oral medications. Paxlovid is an oral medication, and take it from there.
I want to move on to another subject you didn't address earlier. People asked a bunch of questions about long COVID. So can you give us in a nutshell what long COVID is and what people should be concerned about? And I'm going to toss out before you start. Obviously, you can't have long COVID if you just got COVID. There's got to be a time interval of some sort. And so if you would, contextually, are people who got it back in 2020, are we finding that people are all still getting long COVID, or is it something that's dying down or getting worse? What can you share about long COVID, about definition and where it's going?
Right. So there's no question that there is an entity that we're calling the long COVID or long hauler, or there are a couple of terms for this. The problem is that there's no unifying definition. And the other problem, of course, is that a lot of the symptoms are subjective and impossible to measure. So, for example, And it's happening in all age groups. I'm seeing children with quote unquote long COVID. Weight loss, well, that's easy to measure, right? But this fatigue, how do you measure fatigue? Brain fog, all right? Chest pain, digestive issues, anxiety, neurological issues, tingling. So this typically occurs several weeks after initial infection. And the initial infection can be mild, moderate, or severe. We do know that your chances of getting long COVID, whatever this entity is, and again, we don't have a definition for it, so it's really hard to sort of put our arms around this. Your chances of getting this affliction are much less if you get vaccinated versus if you have not been vaccinated. That's an important point. But then it gets it gets very, very cloudy. We know that the virus can have long-term effects. So there's an entity in children called multi-system inflammatory syndrome in children. And this is an inflammatory syndrome that typically occurs about 4 weeks after COVID. And we've seen a lot in children. So there's clearly something about the virus that can induce inflammation weeks after recovery. And so there's no doubt that there's this long COVID does exist. The question is, how do we define it? And of course, we have to remember, for a lot of the patients or individuals who have been hospitalized for a long time, it takes a lot to recover from that at a baseline. So it's sort out, well, are you just in recovery mode after being hospitalized for 3 weeks? Or is this really long COVID? We don't know how to define it. And not only do we know how to define it, we don't know how to treat it. And what the frustrating thing about this, and it's true in adults and it's true in children, is that when you do an extensive evaluation, blood test, x-rays, EKGs, other scans, everything's normal. But there's clearly, these people are suffering. So it would be great if we had a definition so we could say, all right, here we can define the disease as being this, and here are a population of people, and then we can start studying them. But right now we don't have a lot of data on what causes, how long it lasts, what interventions will work. There were some initial reports that suggested maybe a vaccine will help with long COVID. I'm not so, that data was kind of soft. Physical therapy, all kinds of things out there. We just don't have a good answer for it right now.
Is there any data showing it's more common in the elderly, say, than other people, or is it sort of broadly all people, other than, as you said, people who aren't vaccinated, but there's no other trend that our population has to worry about specifically? It's not typical of older people, just whoever gets it, gets it.
Right. And again, some of the symptoms that I mentioned may be more common in older people or in certain populations. And the question is, well, would they have gotten this if they had a bad case of the flu? Would they have gotten this if they were in the hospital after a surgery for a broken leg? It's tough to say, but there's no way to predict who's going to get this. That's, I think, the most important point. You can have mild disease, moderate disease, severe disease, and you may end up with what's now called long COVID.
Real quick, while Jeff takes a breather, because he's been talking, I did send you a few extra links on the chat bar to a couple sources that had some nice answers to questions, and also one to get your free COVID tests. They are available to the general public from the government periodically. You can get a few each. So it was a very easy process. You get online, you get it in the mail. So go ahead and use those if you need them. And Jeff had a quick drink. People, I'm going to, there's so many questions coming in. I'm going to run through them later as we go, other than the ones I've written down. But one question I saw coming by, do you consider these home tests all to be accurate and reliable and trustworthy enough?
Yeah, I do. I mean, obviously you have to use them correctly. And I think they're very good tests. One of the problems that we're running into with the PCR-based tests is that they're very, very sensitive. And if you keep testing by PCR, you may be positive for a long time. So we don't test, well, not to get into the weeds so much, but these are very, very good tests. And I would rely on them. And, if you test positive, you're probably positive.
You mentioned a drug called Paxlovid. When someone is positive, their doctor might put them on Paxlovid, which I believe is an antiviral.
Right.
Is that correct? So is this a drug that someone who is, perhaps immunocompromised should get in advance, such that if I do get sick, I have it? Give us a little bit. I also understand there's shortages, maybe not. So give us a little understanding about how aggressive one should be with that. Who might deserve to get this drug? Who might not? Is it for anybody who's positive?
Right. So what we know is that it seems to be very effective. There's this rebound phenomenon. Maybe I'll talk about that a little later, but that seems to be unusual. My answer would be speak to your doctor. I mean, if you're a bone marrow transplant patient or organ transplant patient, or you're going through chemotherapy, then it may be not a bad idea to have a bottle in your cabinets if you happen to get sick. Now, I understand that the drug is available, so if you have to call your physician's office to get a prescription, that may not be a bad thing. But again, it could be you test positive Friday night of July 4th weekend, and now you're scrambling. So speak with your physician. Just to follow up on the comment I made a moment ago, there are these reports of people who've taken Paxlovid for COVID. They get better, and once they stop it, they get sick again. You may read about this rebound phenomenon. I don't think it's a big deal, and I certainly wouldn't discourage me from prescribing it or using it.
So would anybody who gets COVID, a positive call their doctor, be put on this, or only someone who's sicker or more at risk? Who would be appropriate for this?
I think the people who are most at risk. So if you have any of the risk factors for severe COVID, you're immunocompromised, you have underlying lung disease, if you're a bad asthmatic, for sure, speak to your doctor. But if you're otherwise healthy and you don't fall into any of these risk groups, and you've been vaccinated and boosted, again, I must say that as I told you a moment ago, I've gotten a lot of calls over the last couple of months about people who've been vaccinated and boosted, and they got COVID, and they're, this is the sickest I've ever been. But are you in the hospital? No. All right. Do you need supplemental oxygen? No. Yeah, you feel miserable for sure. But on the relative scale, it's all right. You feel miserable for a couple of days, maybe a bit longer, but you're not hospitalized. You're not on the ventilator. You're not in the ICU. So, the vaccines really work.
Are there any new treatments or treatment strategies coming down the line? We've got antiviral, we've got the vaccine, which is really not a treatment. We've got the antivirals. Is there anything else that is effective or that maybe you think will in the future be beneficial or coming?
Right. So what I see is, we have a lot of tools in our toolbox. You just mentioned them. Maybe refining the vaccines for the variants. Now, mind you, we do this every year with flu. Every year we get a new flu vaccine, but it's based on the viruses that are circulating typically in the Far East. So I can imagine that as this evolves, that we're going to get a vaccine, a COVID vaccine that is based on the strains that are circulating. That would be a great advance, I think.
I think that may be what the question earlier was, is why aren't we doing that? Why is it still the same one?
Yeah, well, I think the issue is this. For every time they reprogram the vaccine, it's got to go through safety trials and efficacy trials. And that's a big, big deal. And
how is the flu one different? Well,
the flu one is different. We have a paradigm based on the flu, and we have a very narrow window for flu, right? So, for example, before COVID, the vaccine formulations would be established in, let's say, March or April for the following season. And so we have 6 months to call it. And then that's it. And sometimes, as you mentioned earlier, Mark, it's a good match. Sometimes it's not such a good match, but it's based on very limited data, very short time frame. So the vaccines that we used last year are not going to be effective for flu. Again, this is pre-COVID. So we have to come up with something new. Here in COVID, we have vaccines that are very effective. They may be a little less effective than they were against the ancestral strain or the original strain, but they're still effective. And I think that's one of the reasons why we just keep using them. And again, the data shows that remains the case. Now, you may have to retool them. We'll have to see how that goes. But to me, I think that's one of the advances. There are going to be more antivirals that are going to be available. We don't know how we're going to do booster shots in the next couple of years. So no, it's extraordinary when you think about it, that we're just at this part of the pandemic and we have all these wonderful interventions.
One of the questions sort of refers to what you just sort of hinted at. It's a little vague, but tell us about pandemic versus endemic. At what point is this not a pandemic? But it's an endemic thing that, as you said, is going to go on, and maybe the strategy will be changing. You see that adults will get shots for boosters, kids won't? Or how will this evolve into sort of our normal life and no longer be the pandemic?
Right. So I think we're actually at a point now where it is endemic. It's all over the place. It's here and it's not going anywhere. I mean, in other words, it's not going to vanish. So it's here and we're going to have to deal with it. And I think that from a public health perspective, we have to change our strategies a bit. On a personal level, I don't think we have to change our strategies. I think you understand your risks and you get vaccinated and so on and so forth. But we're going to be dealing with this virus for a very, very long time. It's not going away. And the question is how we deal with it. Now, if no new variants emerge, then I think there are going to be new variants that are going to emerge that may not take off. They may just burn out by themselves. But if there's another Omicron out there, that's going to change everything dramatically, but it may not be. So we're just going to have to see with this. And they're going to be, I think, next year at this time, May 31st of next year, it could be that there's a sporadic outbreak over here, or there's an outbreak up there, or this city has a number of cases and they're getting a little nervous. But it's not going to be like what we experienced with Omicron, assuming there's not a new variant. So I think that's what we're going to be dealing with.
I've got a couple of small subjects to hit, and then we've got a bunch of questions. I know time is getting there, but I hope we have, I'm not sure exactly what time we're cutting off, but I hope we have a little more time. What, if anything, is being done, or is there any success being made broadly, and I'm going to let you answer the question, be it government or medicine, in terms of the anti-vaccine movement?
This has been, to me, the most two most astonishing things about the pandemic. One is that we have these vaccines, highly effective vaccines developed so quickly, safe and effective vaccines. And the other is the misinformation, disinformation. And when you think about it, we have two foes right now. We have the virus and we have the misinformation. And right now we have better tools against the virus. And I think it was Winston Churchill who said something along the lines that, a lie goes around the world before the truth gets dressed or puts its pants on or something like that. This has been a problem. This is a public health emergency. The WHO has called it a public health emergency. That vaccine hesitancy and the anti-vaxxers are, I don't know how we're going to get around this. People tend to be in their own echo chambers and they listen to this nonsense. And I showed you a little bit of data before, and there's a lot of data out there. If you're not vaccinated, your risk of dying of COVID is much, much greater than if you are vaccinated. And the Brown University study, 318,000 people died unnecessarily because they didn't get vaccinated. And so I don't know how to break that. If anybody has got an idea, let me know. But I will tell you, and I don't know if I mentioned this at the last one of the last sessions. I remember seeing a child last summer, underlying medical problems, 14-year-old, and mom didn't go on to get her vaccinated, and then she got COVID and she spent 19 days on a ventilator. And when I spoke to mom, why didn't you get her vaccinated? Well, I heard something on Facebook. I wasn't, I mean, come on. Your daughter's been in the ICU for 3 weeks on a ventilator for 19 days. This could have been prevented. I just don't know. I really don't know. It's been very, very frustrating.
With all the big news stories recently, there's a couple of medical ones that have kind of, I'm sure some of our people have seen. I just want to touch on them, or let you touch on them. Monkeypox. Everyone's saying, oh, monkeypox. So everything I've read is very reassuring. This is not, it's caught a different way. It's not as communicable. It's a totally different thing. Don't worry about it, but I want to hear it from the horse's mouth.
Okay, so, the late, great Gilda Radner used to say, it's always something. And right now it's always something. Now we got monkeypox. So monkeypox, there's a history with monkeypox. We understand what it is. The virus is actually related to the smallpox virus. And I think many people on the call here have been immunized against smallpox. They have the pimple on their arm. So if you were born before 1973, chances are you've been immunized against smallpox, which will afford some protection against monkeypox. But it seems that monkeypox is not as quite as contagious as COVID. You really need close contact, particularly close contact with a pox lesions. There is some spread in the respiratory route, but it's droplets. So you have to be really close to the individuals. And it seems to be being spread in certain populations homosexuals, people, close contact with one another. So that's where we're seeing it now. So there are, I think the latest number was several hundred cases around the world, and there's
550 as of today. But as I've also read, there have been 0 deaths, which is also important.
Right. So I don't think it's going to be a public health emergency. I don't think it's not going to be anything like COVID. Again, unless you come into close contact with somebody, really close, intimate contact with somebody, your chances of getting it are very, very low.
I think that's real important. Sitting next to somebody on a plane is not how you get this. This is different.
This is different. This is very different. I will tell you, and the other thing is, interestingly enough, is that there's sporadic outbreaks of monkeypox in Nigeria and other African nations. And there's actually a vaccine against monkeypox. But because it's such a rare disease, that the vaccine actually was studied in animal models and studied looking at immunity induced by the vaccine. So we know that the vaccine induces immunity. We just don't know whether it protects you against infection. But because it's such a rare disease, it's tough to do that study. But nonetheless, I don't think there's going to be any mass immunization campaigns for monkeypox. And hopefully this will die down quickly. But once it takes hold in certain populations, well, we have a history.
Hard to eradicate.
Right? Yeah, very, very hard to eradicate.
One other medical story that's even getting less press than the cases, but it's a pediatric thing. I think some people have read about pediatric kids with a hepatitis that's causing, in some cases, liver failure. Is there any correlation with COVID at all that people have to be concerned about, or vaccines for that matter?
No, so there are 2 stories now going about hepatitis. One is a story of there's been documented cases of hepatitis, liver failure in children, not only in the United States, but in England and other countries. This hepatitis of unknown etiology seems to be associated with a virus called adenovirus, actually type 40 and 41. And these are common viruses, so it's not clear why they're causing liver failure now. So that's one story. The second story is that there's an outbreak of hepatitis A, presumably transmitted through strawberries. So these are 2 independent studies, both having to do with hepatitis. The one that we're seeing a lot of cases in children may be adenovirus, but there's an outbreak of hepatitis A in strawberries. If you go to the CDC website, these are organic strawberries. Actually, some of the strawberries were sold at Sprouts and I think Market Street, Aldi's. So there have been a number of places. But go to the website; you'll get information about that. And the one thing I should, if other than all this COVID stuff, if you haven't been immunized against hepatitis A, get your immunization. That's very, very important. There's a safe and effective vaccine against hepatitis A. If you haven't been immunized, get immunized. Because if you've been immunized, your chances of getting hepatitis from eating contaminated strawberries is essentially 0.
Okay, I'm going to hit a run of questions people ask, so we may kind of jump around into some subjects. I'll try to skip any ones that we sort of covered. With, as you said, 80% of the children showing signs of infection, at least hematologically, are we at risk that they are carriers or might be a vehicle to transmit it? Or only if they're not healthy, if they're feeling well, are we safe with them? Right.
So the 80% number, let me just explain where that number comes from. So what these investigators did is they went to a children's hospital or alike, and they got leftover blood samples from children, and they tested them to see if they had antibodies against the COVID virus. And 80% of the samples they tested were positive for exposure to the COVID virus. And they can tell the difference between natural infection and immunity. Of course, kids less than 5 weren't getting immunized, but you could tell the difference based on how they construct the test. So it seems that 80% of children have some evidence of infection. That's an extraordinarily high number. But that may be good news, because kids can be vectors, and if they are immune, they may not shed virus, they may not get infected again. That may really dampen down the pandemic. So we'll have to see how long that immunity lasts. But that suggests that there's a lot of people out there who've been infected, either whether they know it or not. And you get a point where the immunity is so high that the virus starts to decline. This is the I don't want to get into all the nuances of herd immunity, because I think that term is misinterpreted a lot. But as the immunity increases in the population, the spread of the virus decreases.
Next question, how would it be determined if a variant is Omicron versus P1 or something else? I'm not sure if that relates to a given person or in the society, but if you come down with COVID, you're positive on your home test, how do you know it's the current one? Can you know, or does it matter?
Well, at this point, it probably doesn't matter, because it's all Omicron, subvariant of Omicron. So a lot of the places that are doing large scale testing, like UT Southwestern, they actually do sequencing on a large sample size, a large subgroup of samples that come in. And they can tell you that, well, 40% are BA1 and 60% are BA2. So without sequencing your own specimen, you won't know, but you have a pretty good guess. So right now, if you're in Texas, it's going to be BA1 or BA2, and that's it. And so from a medical standpoint, at this point, very little difference.
So someone has mentioned, I'm not sure if it's a study or several studies, but references a study that showed no difference in the caseload of the disease in locations with and without mask compliance. And if I'm not sure if you're familiar with that, I don't know the study, it wasn't referenced. Do you take that to mean masks don't help in the general population, or, and I'm not sure if you know about that study, it'd be hard to comment, I know, without knowing the details.
Yeah, so there's been a lot of stuff about masks and how effective they are. And, you know, as I said, the CDC has a website, it's got 65 studies listed, some very, very good studies looking at efficacy of masks. You know, we've been using masks to stop a lot of respiratory viruses, and it works really well. And so here we are over 2 years into the pandemic. I've been taking care of kids with COVID since the beginning of the pandemic. I wear a mask. As far as I know, I haven't gotten COVID. Now, I got immunized and I got boosted, great. But, you know, up until December of 2020, I wasn't immunized, nobody was. And my colleagues who were in infectious disease, and they never got COVID. So either we're really lucky, and mind you, we're sitting, I'm examining a child with COVID, whose mother's sitting in a corner coughing, and we wore a mask, eye protection, and we didn't get infected. I mean, so this anecdotal studies, and if that's just anecdotal chatter, but masks really work, and there are, and if anybody's interested, I can start sending you some of the really terrific studies that have been done by the CDC, and that show that masks work.
You had mentioned earlier, reference that there's some other human coronaviruses that we deal with and we contend with. One of the questions was, do any of those have associated long COVID associated characteristics or findings, or is this a unique thing that we're experiencing?
Yeah, not that we know of. There's a hint that that one or more of the common coronaviruses may be associated with an inflammatory disease in children called Kawasaki's disease, but that hasn't been established yet. So we don't know. But see, the thing is,
you're saying it's causative, or you're saying people with Kawasaki's?
Well, that there's some link that when if you get in COVID. But you see, the issue here is we have a unique view of these viruses now, because this one virus showed up all at the same time, and millions of people got infected at the same time. If you look at these 4 common human coronaviruses, if they cause long COVID in 1%, right, and they're only sporadic outbreaks, we're never going to figure that out. It's going to be under the radar. The numbers are going to be too small, too scattered. But if you're having millions of people getting infected and it's only 1%, then the signal is very strong, and you could actually start to study and notice it. So, you know, for all I know, you know, the kid who comes in before the pandemic, who had fatigue, maybe they had a coronavirus infection 4 weeks before that. I don't know, but you know, again, it's the numbers that drive all this. And that's why we're detecting it.
So I know this may not be possible, but what is the harm of getting a booster every 4 to 5 months if they're available and if someone would give them to them? I mean, they may not be allowing that, but why not get a booster every 4 or 5 months until something new developed? Is there a harm to that? And if so, if there's not, why don't we do that?
Well, we haven't studied that. There probably are studies going on right now. And of course, we're studying that in real life, right? We're seeing how people do after getting vaccine boosters. It's the data suggests now, other than some, people have gotten local pain or felt crummy for a couple of days after the vaccine, there's probably no downside to it. So I don't, but until we have a lot of data, we'll have to wait and see.
Michael Kastner brought up an interesting topic. For the first few rounds of COVID, we kept hearing that Israel was leading the edge. They're doing things. We got a lot of studies from Israel. We haven't heard that. Is there a reason for that, or just they're not? Has there been a change in their strategy, or are we hearing anything from them, or is it just sort of that it just hasn't been the case for no good reason? They seem to be the leading bit of information all along for a good bit of this.
Oh yes, and I think they remain that way, and they're the ones who started with the first boost, with the first rounds of booster doses, and we took the lead from them. And they have some wonderful studies that are published in the top medical journals. So no, the Israelis have done a wonderful job, and they have a health system that can track a lot of this, where ours is a little bit more disjointed and confusing. No, the Israelis have been out in front, and I have colleagues in Israel, and I hear from them occasionally, and no, I think the Israelis have been doing a wonderful job now. They're dealing with all kinds of other stuff.
Yeah,
actually a polio outbreak in Israel, believe it or not. So, as we said, it's always something.
Two more quick questions or areas I want you to cover, and we're going to wrap it up. David's giving me a hint here. And it matches to somebody's question. We've got someone who actually has COVID now. So, if someone does have COVID, once they're well, should they get the booster? And also give us a little information about your home test. If you're positive, or if you have a positive test, when should you expect it to be negative? Does it matter? If you are sick at home, when can you feel comfortable getting out there? So kind of give us you've got someone who has COVID, how should they handle it?
Right, so let's break it up a little bit. So if you test positive for COVID, the CDC has sort of staged recommendations, 5 days, 7 days, 10 days. And basically, if you test negative after 5 days, you're probably good to go. Right. That's unlike.
So you should do a second test at home.
Right. Or 7 days. I think that's probably a better time frame. And then they say by 10 days, if you're fever free for 24 hours without the use of Tylenol or Motrin or other antipyretics, and you're fever free by 10 days, and you still may have a cough, but if you're not, if you're symptom free from a fever standpoint, you're good to go. I think a lot of people do the repeat testing too often, and it's positive, and it drives them crazy. And so the CDC has a nice table about this, and it tells you exactly what to do. So follow their recommendations, and of course, if you follow the recommendations and you're going back to work or you're going back to school, you can say, hey, here are the CDC recommendations. I followed this, and here it is, and I'm good to go. So that's the story with if you test positive. The next question about boosters. The booster dose really depends on when you had your last vaccine dose, right? So that's what determines when you can get your booster dose. So it's not necessarily when you got, if you happen to get COVID after your second vaccine dose. So for example, if you got your second vaccine dose last week and you get COVID this week, no, you shouldn't get a booster dose. You should wait the 5 months or so that's listed in the recommendations. Beyond that, if you have COVID, we don't have a lot of data on this. Some people said, well, you have to recover first and then get your booster dose. Some people say just get your booster dose. I don't think it makes much of a difference.
You said the COVID is protected for several months anyway. The booster may be longer, but 4 to 6 versus 2 or 3.
Right. If you have COVID now, you've been immunized, and you're within the period, or you're beyond the period where you could now get a booster dose. Or I'm sorry, I said that incorrectly. You're now at a time where you can go ahead and get a booster dose because you're far removed from the last initial series. If you want to get a booster dose after you got COVID, go ahead and get it. Go ahead and get it. Absolutely. Get it.
Our final question, again, this is maybe a tough one to answer. Some people have the opinion that, COVID has really become sort of like the cold now. I get it. I'm sick for a few days. It's no big deal. I'm protected. I've had my boosters. I don't need to really change my life to prevent having it. It's not a big deal. Other people feel that's all true, but then I could get long COVID. which we don't know much about. So, and there's no right answer. Do you have any input in that thing? Is it, I don't want to say cavalier, but is it cavalier to say, oh, it's just a cold, no big deal? Or is it getting to be a practical thing that, yeah, the chances are I can treat it that way?
Yeah, I think, as I said earlier, I think from a public health perspective, we have to sort of shift our views of this. It's endemic, we have to deal with it. And I think if you've been immunized, chances are you're going to get a mild infection, mild being not hospitalized. And yeah, I see that argument. I see that saying, listen, if this was before COVID, if I got a cold and then my wife got a cold and my kid got a cold, we say, hey, we got a cold. I got a cold, I passed it on to her. We never thought twice about that. Or even with the flu, we got immunized. And so I think we have to start thinking about it in those terms. On the other hand, we do have a responsibility to the people around us. And I'm not just talking about the people in our family or the people in our household. We have responsibility to people in the community. And, if you're sick, you shouldn't go out. And, everybody should be immunized. And that's what we have to do. So I understand the argument is that now it's a common cold. And before COVID, we never did anything like this. And I sort of get that. I understand that. There are a lot of complexities here, as you mentioned. And each individual's got to weigh their risks. But again, you're if you've been immunized, and you're smart about it and you're cautious, you speak to your physician, maybe have some Paxlovid around, that may be the deal. Now, they're going to be severe cases, right? So you do take your chances. The data from Dallas County, I didn't show this tonight, but they look at people underlying risk factors. 25% of the people who have died in Dallas County, 25% of the people who died of COVID in Dallas County did not have an underlying risk factor. So that's a pretty startling number. And so I think people have to keep that in mind.
Well, thank you very much. And thank you all for sticking around a little bit. We had a lot of questions. I'm glad we could get to them. David, I'm going to turn it back over to you.
Okay, thank you, Mark. We really appreciate all the information that you all are able to disseminate. It's always so valuable. I just hope you guys have a sense of how much we appreciate it. I'm going to turn this over to Dan. He has a few comments and then we'll wrap this up.
Yeah, thank you, David. Guys, Jeff and Mark, you covered an incredible amount of ground tonight. I had a booster shot last week, and I feel like this was my information booster to follow that with all of the different topics that you guys covered. So I want to, of course, thank you again for taking the time to share your knowledge and expertise with us. Both of you, and Mark for moderating, and Jeff for all the slides you put together and the information that you shared. We appreciate it. I thought this was the fourth one in the series. I was surprised to learn that this was number 5. So we have really been going at it, and you guys have been very gracious to do 5 of these for us. I'm not going to make the comment that I hope it's the last, because we know that this is just an ongoing event. But thank you guys again. And I also want to say thank you to David and Phil and the members of Hazak for putting this together for everyone. So I hope you all have a great night.
Thanks,
Thank
Dan.
you.
And everybody, thank you. And specifically, thank you, Jeff, and thank you, Mark. We really appreciate it.